Welcome finally to the fifth of the summer sessions for 2025. I'm Tim Gibbs. I'm joined by Nicole Sabine, colleague of mine with the Academy. If you've got any housekeeping questions, please email her rather than me, because that's one of the things that she does far better than I do. Just remember, no tests or grades, stay to the end of the presentation. The presentations and the video sessions are available at delawareminimed.org. And as I said, contact Nicole. There's her email address. Today we're at Child Life with Nemours, and we're joined by two colleagues, Sarah Brakoh, MS CCLS, and she'll tell you all about all of those. Sarah was born and raised in central New Jersey and left Jersey in 2018 to pursue her bachelor's degree in family and human services at Towson University. She started off as a sociology social work major at another university and always had an interest in the medical field, teaching and working with children. Her intro to social work course led her to find out about the field of child life. It seemed to be a perfect fit because it integrated teaching and advocacy in a perfect way. Sarah went on to pursue her post-baccalaureate degree in family collaboration and then her master's degree in child life and administration, also from Towson. She has been an emergency department child life specialist at Nemours Children's Hospital for a little over a year now, and her favorite part of the job is from watching kids go from scared to empowered to do hard things. If she had a superpower, it would be to read minds. And then we have Meredith Krewson. Meredith grew up in New Ringgold, PA, studied biology and dance at Muhlenberg College. She graduated in 2020, and she had no idea what she wanted to do. She took a gap year, in other words, a year off, and served with City Year, which is an AmeriCorps program to support students at risk of push out. And push out is when students leave high school for usually reasons that are non-academic. They had to work, they felt threatened or somehow at school. She can talk more about that. But she realized through that she wanted to pursue a job in which advocating for individualized care was the focal point. She learned about child life. It seemed like a perfect blend of her biology past and her current student support experiences. She enrolled in graduate school and learned her M.Ed in child studies at Vanderbilt and became a certified child life specialist in 2023. Meredith has worked in the Nemours Emergency Department ever since, which has been almost 2 years. Her favorite part is being able to meet families where they are in a place where they typically don't want to be. And if she had a superpower, it would be speed. So mind reading and speed and superpowers, and I'm going to stop share and turn it over to our colleagues. Welcome.
Hi guys. Once again, we apologize for the technical difficulties. My name is Sarah.
I'm Meredith.
And we're both child life specialists here at Nemours, and we're going to be presenting today on what is child life providing psychosocial support in the emergency room. So a little bit about me. My name is Sarah Brakoh. I am a certified child life specialist. I have been for the past 1.5 years at Nemours Children's Hospital, primarily in the emergency department. I went to Towson and I graduated in 2022 with my bachelor's in family and human services, and I graduated in 2023 with my master's in child life and administration, and also a post-bac in family collaboration. Currently, I am a PhD candidate studying counseling and psychological studies, focusing on trauma and crisis counseling. And my work here is really what prompted me to focus in trauma and crisis counseling. A little bit of personal stuff about me. I am from central New Jersey, Old Bridge to be specific. And on my free time, I love going into the city of Philadelphia. It's like a 40-minute drive from Delaware, and trying new restaurants. So a little bit about my journey to becoming a child life specialist. I wanted to be an education major for as long as I can remember, ever since I was a young girl. And then I realized in high school that I wanted to make a little bit more impact on the community. So I declared a social work and sociology double major at the University of Maryland Eastern Shore. Now, that was not my first choice school. I did want to go to Towson University straight from high school, and I did apply, but I was rejected. So I took another route, did a social work sociology major, and realized in my intro to social work class all the different areas that social work could be utilized. So I really had an interest in medical social work. So from there, I did a quick Google search and I was like, okay, what are other fields related to medical social work? And I saw child life. And I realized that it was the perfect field for me because it kind of merged the education piece that I always loved and the advocacy piece that I loved from social work. So from there, I looked at schools, and Towson was the only school that had the in-person program for child life. And I was like, well, I'm going to take another shot at it. So I ended up going to my number one school, graduating from my number one school with my bachelor's and my master's. Um, so between 2020 and 2023, that's when I obtained all of my clinical experience. So I did 100 hours of volunteering at Sinai Children's Hospital in Baltimore. I primarily volunteered on a inpatient oncology unit. And then I completed 100 hours for my practicum at Kaiser Permanente, where I shadowed a one-person program child life specialist who worked an outpatient oncology clinic, urology, and outpatient surgery as well. And then I completed my 600-hour internship at the Children's Hospital of Philadelphia before I accepted a job here. And between the years of 2022 and 2024, I completed my graduate coursework. Um, Towson University does have a 4+1 program, meaning that you could get your bachelor's and your master's in 5 years instead of the typical 6 years where you graduate and then you have to reapply. So in your senior year of your undergrad year, you start taking graduate coursework. So that's how I was able to do it in 5.
And I'm Meredith. I know you heard a little bit, excuse me, about me and our introductions already, but kind of diving deeper into my experience leading to child life, I had a bit of a winding path. I have now been a certified child life specialist for 2 years in the emergency department here at Nemours, but I went to school originally for biology and dance in college, and then ended up going back to school to get my master's in child studies with a concentration in both pediatric healthcare and poverty and intervention. And along the way in that journey, I became a certified infant massage instructor as well. I was born in Pottsville, Pennsylvania, and I love going to the beach, reading, traveling, visiting friends in my free time. A little bit more about the exact journey. I went to Muhlenberg College from 2016 to 2020. Like I said, I studied biology and dance. I had no idea what I wanted to do. I thought I wanted to work somewhere within the medical field in some capacity. So a lot of my undergrad experiences were kind of geared towards externships and volunteering and shadowing within the hospital setting to just kind of get those overarching hours that could be applied to a lot of different things. And I did end up volunteering with a child life program in the hospital throughout college, but I actually had no idea what child life was at the time. It was just the only thing available for volunteering at the hospital. So I jumped right on into that. In 2020, when I graduated, I took a gap year, partially pandemic related, partially because I still was like, I am not totally sure what I want to do. I just know I love working with kids and I'm really interested in medicine. So I worked with this program through AmeriCorps called City Year. It was an educational equity program, really focused on supporting students in large classroom spaces to have more individualized kind of learning plans. So I worked alongside the teachers, not as a teacher, but as someone who could support psychosocial and learning needs of kids most at risk for being pushed out of the public school system. And within that year, I really fell in love with advocacy work and being able to work one-on-one with kids and really meet them where they were to support their growth and learning. Sorry. And because I loved that so much and I loved the medical fields aspect so much, I took to Google as well and was like, what can I do with these two loves? And child life popped up. And I remembered, oh my gosh, I've already volunteered with them. I kind of know a little bit about it. And so then I started applying to grad schools from there. I am quite indecisive, so my application to grad schools was a little more broad. I wanted to find one that I could be able to apply to child life programs and internships, but I could also have sort of a larger learning experience in case I ended up not wanting to go that route. So I went to a grad program that was child studies specific. So I got the 10 courses that are required, which we'll talk about in a little bit. But I also was able to have supplementary coursework alongside of it. So then within that grad school year, that was a 2-year program. I completed my practicum at Penn State Hershey and then my internship here at Nemours, and then applied to jobs from there. Brief history. I know we're kind of a little bit late on our time here. Thanks again for bearing with us, but this just walks you through a little bit of the child life profession. Really just wanted to put this in here to point out that it has been around for a while, but it really is still sort of a newer kind of thing. 1922 was when there was this initial sort of request to develop these play programs in hospitals versus the original thought was like, get the kids in here, strip them kind of their parents because we don't know about infection and we don't know about infection control. And now it's this idea of, oh, let's make this place a little bit more normal so that we're tending to the psychosocial needs of children in the hospital setting. And now we're currently 20 years ago, 2005, not 2025, membership for Child Life has reached more than 3,000, and it's continuing to grow and continuing to be something that is implemented in mostly children's hospitals, but now more of a focus on even more adult-centered spaces or classrooms, funeral homes, educational centers. It's growing, which is wonderful.
Talking a little bit about the role of a certified child life specialist, we wear many hats while working in the various workspaces that we find ourselves at, but we wanted to touch upon these 4. We primarily support coping and emotional regulation in children and their families as well. And this could look like engaging children in deep breathing techniques and also counting techniques to help a child feel more in control when it comes to things that are scary and procedures that might present with a lot of anxiety and stress. Another thing that we focus on is procedural preparation. So we use teaching dolls, we use the real medical equipment to help explain procedures and to help reduce anxieties and also to address common misconceptions about medical equipment. And we also collaborate a lot with the medical team, and not just the medical team alone, but everyone who works in the emergency room. So that looks like your attending doctors, your physician assistants, your nurses, radiology techs, everyone who encounters a patient. We really collaborate with them to kind of assess the timing of procedures, discuss comfort positionings, and also have a better and clearer understanding of the procedures that will be taking place. And also, we are big advocates. I know you've heard us both use that terminology a lot, but that's really the core of what we do. We advocate for the psychosocial needs of our children and their families. We realize that hospitalization, especially an emergency department visit, is not necessarily always planned. And we know that people are people and they have needs, wants, and priorities as well. So we like to meet them where they're at so that we can provide the best psychosocial care to help them feel safe.
Goals of our job, kind of like Sarah has already mentioned, normalizing the environment, making sure that the hospital, what we're doing is trying to take away some of the stressors that could potentially be present in a hospital setting, and hopefully optimize outcomes of patients and families and help reduce some of the potential traumatic experiences that they may have while they're here. We want to address anxiety regarding hospitalization, and we do that through our therapeutic interventions. And we also hope to help patients and families understand what procedures will be going on and how they can cope with them. So giving some voice and choice back to children when they're in this space. We may have to do this next step. We might have to do an IV or have to get stitches or have to get a CT, but how can we make it a little bit more normal? And how can we come up with a plan to help you cope with getting through these next steps and feel like you have a sense of control? Maybe you're picking out who's holding your hand during it, how you're sitting on the bed. Maybe you're picking out the color of your Band-Aid. You're picking out the timing, if you want to take 5 breaths and then do it, if you want to hold up a sheet to block your view, all these kinds of choices that come into play and allow kids to feel more in control. And a lot of times we do this through play too, which is kind of the ultimate language that kids are using to communicate. Like Sarah said, we're always advocating for family-centered care and recognizing that people are coming here with a whole host of things going on that have nothing to do with the chief reason that they're presenting to the hospital. We're also working as part of the whole team and making sure that while the doctors and the nurses and the NPs and PAs, while everyone's focusing on the medical side, we're kind of there to focus on the emotional safety piece and the psychosocial piece. And ultimately promoting mastery and control for the patients that we see.
So talking about the path to certification, we talked about the education piece. So the Association of Child Life Professionals, which I'll refer to as the ACLP, requires a bachelor's in child life, child development, psychology, or any related field. And a master's degree is suggested. And then from there, they require pre-internship experiences. You need 100 hours of volunteering in a hospital setting and 100 hours of a practicum or pre-internship experience where you are shadowing a certified child life specialist in a hospital, school, funeral home, campsite, wherever that you may find one. And from there, you're able to apply to internships. Internships are are across the country. Some may require you to move, but the internship experience is where you can really move on from the shadowing into becoming independent. It's really the step that gets you prepared for the workforce. And that's a 600-hour internship, which spans over the course of 15 weeks, like a full semester. And then from there, you're able to sit for the certification exam. The certification exam is an exam that tests your knowledge and your skills. And you do recertify every 5 years by obtaining continuing education credits. Or if you don't meet the requirement for the 60 credits at the end of 5 years, you will have to sit for the exam again. So option one, we briefly spoke about this based off of our individual journeys, is graduating from an ACLP endorsed academic program. So this looks like the certain colleges that are endorsed by the ACLP, they would have the 10 required courses built into your bachelor degree coursework. So for example, I was a family and human studies major, but I was also an introduction to child life track. So as I was taking my adolescent psychology, child psychology, I was also taking my bereavement courses and my play courses, making me a fit candidate to be a child life specialist at the end of my degree. This is the easier route because you don't have to worry about, is this class going to account for my class credit or anything like that, because it's already an endorsed school.
And then option two is how I landed in child life, a little bit more of the winding path to get here, but if you're indecisive like me, this worked well for me because I wasn't sure in undergrad what I wanted to do. And this is the way that you can obtain the coursework and get those 10 courses that Sarah was talking about through a more broad sort of lens. So I specifically looked for graduate degree programs that allowed me to get these 10 courses so that I would be a candidate for internship at the end of it. But I had to go through a little bit more hoops in a way to sort of get them approved. So there is an extra process of kind of showing the ACLP what coursework you took and applying in a way to get those classes approved. And then once they're approved, you're able to be considered a candidate for internship. So now we'll kind of dive a little bit more in detail of what we do on a daily basis. There's kind of three overarching themes of our role: preparation and education, support, and then play. So we'll walk you through those, and we brought, you can't really see them over here. We brought a whole bunch of the prep kits that we use to sort of allow for kids to be able to look at that real medical equipment, like Sarah said, and play through it and process through it and know what's coming next. Our big focus is on preparation first. So we don't ever want kids to be surprised by what we're doing here at the hospital. We don't want them to feel that sense of being out of control, like we just poked them and prodded them and they're like, have no idea what's going on. It's really important for us to be honest. I'll show you an example of one of our preparation dolls that we utilize quite a bit. And sometimes we'll take these in, hopefully you can see, oh, Just kidding. I'll back it up to me. Hopefully you can see this. This is one of our shadow buddies, and we have ways to make these more customizable to the patients we're seeing. But this one has an IV on its arm. So oftentimes we will walk through all the steps with the kid first. We'll bring in all the materials for the IV, and we'll allow them to utilize all of them to put the IV on a doll or on their stuffed animal or on an action figure. We'll walk through, putting the tight rubber band on their arm first, cleaning their arm with a little cold sponge, what it smells like, what it feels like, talking about, there will be a little pinch, but here's all of the things we can do to help with that pinch and make it less of a pinch. And Sarah will talk about that a little bit more with support. But that's one of the things that we'll do. We have our cast doll that we'll bring in, our lovely Yoda, to show them what the cast will look like and feel like. So a lot of our preparation is based on, sensations, smells, tastes, feelings, temperatures, and then if there will be a pinch, if there will be a part where they're expected to stay still, how we can then come up with a plan for support throughout that. So we're giving a lot of pre-procedural preparation. Sometimes we give some post-procedural preparation or explanation. So we may not always be able to get there before things happen, but how can we help kids process through what just happened afterwards and give them a sense of control back? Like, maybe we just had to do this IV really quickly because this is an emergent situation, but now we can put an IV on your stuffed animal and you get to be in control of that and pick which arm you want to put it on. Sometimes our preparation is for things like CT scans and MRIs. We have our Lego MRI over here, which might be a little tricky to see, but hopefully it's not too blurry. But this is our Lego MRI, and kids can push the little Lego person through it, see how the MRI works, how it spins around and has a camera. We also have a ton of preparation books on our iPads with pictures of every room in this whole hospital. So if they're going to surgery, we walk through every room that they'll see before their surgery so that they know what to expect and what they're going to be seeing and where they're going to be waiting. And sometimes it's just preparation for staying over at the hospital and knowing, what to expect in their room and what it will look like. So that's kind of our big chunk of preparation and education. Sometimes it's education on specific diagnoses. We do a lot of diagnosis teaching. We have books for every developmental level about new diagnoses, diabetes, cancer, if we're staying over at the hospital because we don't know what's going on. So we'll walk through kids through all sorts of things beforehand to kind of give them that sense of knowledge and education back, but in a way that's tailored to them and not big medical words that they're not understanding necessarily all the time.
So yeah, moving on to that, Meredith touched upon some of the support, but again, just touching upon some of that diagnosis education piece. There are oftentimes we see parents also feel like they think that their child is not prepared for that. And we understand that and we leverage that. So we would then provide handoff to child life specialists that are in the inpatient unit that will be spending an extended amount of time with them to provide them with more of that educational piece. For procedural support, we really aim to provide distraction and promote relaxation during procedures. We're not here to lie to them. We want them to know that that is coming, but we also want them to have their mind on something else. This is one of my favorite distractions. It is a resin I Spy disc. And I love this because it's very interactive. It gets the child talking, it gets them distracted because they're focusing on looking for something in this resin. We do also help with pain management, both pharmacological and non-pharmacological. One of our favorite non-pharmacological pain management tools is using this Buzzy. I don't know if you guys can hear the vibration. It's very faint, but Buzzy is scientifically proven to help reduce the feel of a poke. So what we would do is, for example, if an IV was going in one of the veins here, we would place Buzzy about here. And what Buzzy does is he tricks your brain sensors to focus on the buzzing sensation rather than the poke. So this is one of our favorite non-pharmacological pain management techniques. When it comes to pharmacological pain management, we definitely are big advocates for pain ease. This is, it's kind of like a lidocaine spray. So it goes on just like so, pretty cold. Sprays, it's most effective when a professional sprays this on for about 10 seconds and it numbs your skin. And we like to tell children that it makes your skin fall asleep for a little bit so that you don't feel the poke as much. These are all ways to help children cope better through procedures and provide that support. We also are here for the whole family unit. It's a common misconception that because we're child life specialists, developmental experts, we only focus on the child. But we acknowledge the family systems theory, which states that what affects the child really affects the whole family unit. So we're here for the caregivers, the siblings to provide support, education, and just helping normalize their environment. And then we also provide bereavement support. As a part of our coursework, we do have to take a bereavement course. And when it comes to end of life needs, we are always offering keepsakes. So, for example, this is a keepsake. This is from a baby doll, just letting everyone know. This is one of my first keepsakes that I made. So we would use plaster and water and all of that stuff to kind of make a realistic footprint and handprint. We would take the deceased child's hand or their foot so that their family has something to remember them for. Talking about play, there are many different types of play, but the three types we wanted to touch on today are normative, medical, and therapeutic play. A normative play session looks like a parent really just needs a break, needs to step out, and the kiddo is just kind of hanging out, already got their labs, kind of waiting for results. And I just step in and I'm like, hey, do you want to play a round of Uno? And we're kind of just talking about their summer, talking about their siblings and what they look forward to for the upcoming school year. So that's like a normative play session to kind of provide opportunities for social interaction. When it comes to medical play, this really allows for patients and siblings alike to explore medical equipment and then also in a non-threatening manner. So in this way, I'm also able to assess their understanding of these medical equipments. For example, if I give the child the shadow buddy with the IV and the child proceeds to take this and poke it in the shadow buddy's eye, I then am going to ask some more questions because now that child is associating an IV with the feeling of a poke in the eye. So I want to know what they know about an IV and why do they think that that action was appropriate. Again, not in a non-threatening manner, just in a way to clear up misconceptions. And lastly, therapeutic play, which is goal directed. So this is the type of play that I love to use in the older population or in children that find it difficult to verbally express their emotions. There are different play techniques that we can use to help them open up and also to help them process their emotions.
So, talking about some of the language that we use, like Sarah said, we always want to be honest, but we like to use non-threatening language when we're preparing kids, when we're talking about next steps, when we're talking about procedures. We're never lying. We're never trying to trick them when we utilize distraction and alternative focus. We're trying to give them something else to do. While we have to do this hard step, you get to pick some of the other things that we get to do. So part of giving that voice and choice is making sure we're telling them what the next steps are, but using developmentally appropriate lingo. So when we talk about an IV, we often call it a medicine straw or a helper straw. We keep them on our badges at all times so that we can show kids, this part is just a bendy straw. After we do the pinch, we throw the pinch away. We just keep the bendy straw on your hand or your arm. We show them how to squirt water through it so that they can see that it's like a straw and they can squirt water all of their parents if they want to. We call sutures or stitches string band-aids. We have a whole kit that, we walk through all the steps and the water and the cleaning, and we show them the strings and that these look like scissors, but they can't cut anything. They just hold the string. So we call them our string band-aids. If we have to do something invasive like a shot, we call it a pinch or a poke. So we're explaining the feeling and the sensation, but it's a less sort of threatening word for it. Any sort of stickers that we have to stick on them for monitoring heart rate or oxygen levels, we call special stickers or light up stickers. The sticker that makes your finger red when we put the pulse ox on. The pain ease spray, we often call freezy spray or Elsa spray or Frozone spray. The LET, which is like the topical numbing cream, or the LMX that we put on oftentimes if we're going to do a pinch or a poke, we'll call the marshmallow cream or the goo that makes your hands sleepy. If they're getting admitted to the hospital, we call it a hospital sleepover, and we show pictures of what it looks like upstairs and walk them through that transition. And then CT and MRI, we call it the big giant donut or the spaceship that you get pictures taken in. So those are just some of the words and terms that we'll use to give that honest explanation, but in a way that's a little bit less scary.
So you've heard us talk about all the things that we do. So we wanted to briefly touch on what a day in the life typically looks like for us. I am a day shift child life specialist, so that means I work the day shift 5 days a week from 8:30 to 5 p.m. every Tuesday through Saturday. So what I do when I first come in is I attend our morning huddle, which starts at 8:45 a.m. So that's just a huddle of all child life specialists to give us information about what's going on in the hospital, what resources we have available to our families. And it also gives us an opportunity to shout out our colleagues for the good work we've seen them do, not just on the child life team, but hospital wide, which is great. And then I look at the emergency department track board. Here I'm able to assess any patients that may need any support for any upcoming procedures. I'm able to see if there's any upcoming imaging, lab work, and I'm also here to see their chief complaint, their age, and factor all of that when making my list of priority patients. So then after that, I make my list of priority patients. So for example, on July 15th, I saw a total of 10 patients between the time of 8:30 and 5 p.m., and I missed one priority patient. I supported 3 IV procedures, and with all of those IVs, I was able to utilize the shadow buddy and have them practice step by step, putting on the tourniquet, practicing their deep breaths, their coping techniques, and kind of just figuring out what they're going to do during that procedure. And I was able to assess their understanding and get them from a point of, oh, an IV is a huge needle to actually an IV is a bendy straw that's going to rest in my arm and I don't go home with it. So I was able to do that with all 3 patients and come up with a coping plan. We do get traumas. We carry around a pager and we're notified of our traumas. So I supported a young boy who was in a pedestrian to vehicle accident. He was awake and alert and oriented when he came in. So I stayed at the head of the bed and I'm kind of there to walk him through everything that's happening. Oftentimes, there's a lot of people trying to make sure that we have his trauma lab work done, making sure that his GCS score is appropriate. So I'm there in his ear, kind of walking him through the feelings, the sensations, and the people that are in the room. I provided a stress ball to a patient as a positive coping technique so that they can use that to kind of exert any negative feeling into. I supported one laceration repair by prepping them, telling them about the string band-aids, and the position that they lay in is oftentimes uncomfortable. You're just laid flat on a bed looking at a ceiling. So I brought in my tablet and we watched some Disney Plus. And then I checked in on my other 3 families just to assess their needs and make sure that they were coping okay. So at the end of my day, around 4:15, 4:30, I oftentimes chart on all my interventions. I debrief with my colleagues, the good, the bad, the ugly, and I provide handoff to Meredith about the patients I saw and the patients that I feel like would need a check-in. And then I clean and restock any of the prep tools used so that Meredith has enough for the night.
And then, oops. My typical schedule is from 1:30 until midnight. So I will get handoff from Sarah about who she's seen throughout the day, if there's any needs that will come up later in the night that I need to be aware of. And then I'll also look at our emergency department track forward to kind of assess, okay, who's going to be having a procedure coming up, who's going to be needing lab work soon, who's going to be a consult to another team in the hospital that I want to be aware of and be around for in case we do have to do any of those next steps. And so I can sneak in there, learn what the procedure is from the other medical team members, and then take what I know about it and explain it in a developmentally appropriate way to the patient that I'm going to see. So that's kind of what my start of my day will look like in the afternoon. And then I'm here throughout the night until midnight. Majority of our team leaves around 7, between 5 and 7. So sometimes I will be the only person in house from 7 on to midnight. So sometimes that means that inpatient units will be consulting for certain things. So on July 15th, one of the things I did was reach out to our ICU team regarding a possible end of life support need so that I could factor that into my prioritizing and make sure that I'm around if that becomes something that they need child life support for any keepsakes or family support, talking with siblings and explaining next steps and potential grief and loss to siblings and getting an understanding of what best would be supportive for the family. I saw a total of 12 patients between the time of 1:30 and midnight. I missed 5 priority patients because oftentimes when you're in trauma or a medical response, or you're in a procedure for a lengthy period of time, when there's only one of us, we'll kind of be there for quite a bit, and we come back out, and some of the patients we meant to see are already upstairs and admitted, or some of them have already left. I supported 2 IV procedures, utilizing a lot of the same techniques Sarah talked about, with pre-procedural preparation or in the moment preparation. If it was a quick, one of those was a very quick IV that we had to do rapidly, so kind of giving some verbal narration of the next steps while they're already happening, because sometimes our prep is on the fly. And then I supported caregivers during a medical response for an infant seizure. So what Sarah was talking about with traumas coming in, a lot of times we'll be at the head of the bed, being the people that talk to the patient and let them know all the things Sarah said, what's going on, who's in the room, what the next steps will be. Sometimes if those responses come in and they're infants, or it's not appropriate for us to be at the head of the bed because the team needs to work on airway protection, we're oftentimes with caregivers, sort of doing the same thing, but caregiver version. So explaining who's in the room, if they need to step out for an x-ray, we're walking with them and we're taking them back in the room. If things are really overwhelming and they are needing a break, we take them to a spot where they can have a break and we hang out with them. If siblings are present, we take siblings into another room and kind of talk them through what's going on. So my support that night looked more like caregiver support, and then supported an orthopedic procedure for blocking their finger and numbing it. So, explaining the pinch and the warm feeling, making sure that they're adequately numb, and then helping remain in the room while they got a cast. My documentation looks similar to Sarah's. I chart everything on Epic as well. And then since there's no one else in the hospital to hand off to, we use a system called an iPass. So we have our chart system, and then we have a secured way of sending any more detailed handoff to our child life team in a secured Excel document. So if there's something that's coming up, if there was a new diagnosis in the ED, if there was a trauma that I think I've assessed family could really use continued support, I put things like that in the iPass so that our team is able, as child life specialists, to open it up the next morning and have a heads up of, hey, like, these are the units that might be seeing this patient. These are the things that might be coming up. And here's all of the things that I talked about with them that they know so far, so that we're all on the same page and we're all using the same appropriate language. And then that's my way of notifying day shift specialists of what's going on. So that's kind of how I'll end my night.
Well, we wanted to open up for any questions.
All righty. Thank you very much. I don't see any questions in the chat right now. But folks, if you have any questions for our presenters, go ahead and put them in the chat.
They'll definitely start rolling in. That's usually how it goes. One thing I'll say is that I definitely got a little bit of a giggle when it was like the Elsa spray. I have a 4-year-old niece, and I've had to pull the Elsa card on her to tell her that she needs to use ice when she has like a swollen ankle or something, because she refused to. She's like, I don't want that. I don't want that. I'm like, but Elsa made it, and she's like, okay, give me it. So she's like,
Yes, sometimes it's about like just changing the language. So it's like,
yeah.
oh, this is something that's more familiar to this kid where they are developmentally, and now I want to do it, and now I understand it
Yep.
because it's in my lingo and it's in the things that I understand and that I like.
Yeah, so that one made me, I definitely enjoyed that one. Oh, we do have a question came in. What is the hardest part of your job?
Hardest of your job.
That's a good question.
Yeah. I would have to say the hardest part is disconnecting my personal self from these families. I need to understand that I'm doing my job, I'm meeting them where they're at, and if once they leave here, they leave here. Oftentimes it's hard to not take things home and kind of ponder, to wonder, like, is that patient okay? Or if it was an end of life situation, like, wow, that accident was really traumatic. That accident was really bad. But I think that when they do move upstairs, the thing that helps me is knowing that they're still going to be supported by other child life specialists. And when it comes to end of life, just making sure that I process all my emotions at work. And when I go home, I do something that also fills my cup.
I'd have to echo that as well. I think that's the separation is kind of tricky because we are in a really unique spot where our focus gets to be on the emotional needs of families. And oftentimes we're really connecting with them because part of our job is to build this rapport so that they look at us as someone that they can trust. That's not the person that's going to be doing the things to them. So we're not the people doing the IV. We're not the people doing the stitches. We're a person that they can kind of rely on in other ways. And that's a beautiful thing, but sometimes it's really tricky, like Sarah said, to be able to separate yourself and recognize like, okay, I have to try to leave this at work when I leave this place.
Yeah, I can imagine it's hard to compartmentalize, like this is like, as you had said, the speaker is like, this is my work life, this is my home life, I can't bring it home with me, kind of thing.
Exactly.
Oh, we do have a question. It says, does your 100-hour volunteering in high school count toward your required graduate hours? Or when should they be doing these hours? And I guess, is it like cumulative, or do you have to do it during undergraduate? How does that work?
Yeah, that is a great question, but no, you don't have to do it during undergrad. Your
Okay.
100 hours of volunteering in a hospital does count when you're in high school.
Okay.
And sometimes they appreciate different sorts of volunteering too. So, like at one point in college, I volunteered in the gift shop during COVID because they weren't allowing volunteers to do any sort of patient volunteering. And those hours counted towards hospital hours. Sometimes for certain things, they appreciate more direct patient contact hours with child life. But other volunteer opportunities also can count too. So even some of my work in a daycare during grad school counted towards some of my hours. So there are different chunks that are able to count for different things. If that makes sense.
Yeah, so students could start earlier, I guess, if they wanted. They could be like,
Yeah.
start as early as high school and then
Yeah.
build up their hours. Okay.
Yes, just put it all on your resume.
Yeah. Make sure you document it.
Yes.
So this question from Emily, obviously you guys do work with child patients, but what is the typical age range of the kids that you work with?
It's anywhere from 7 days old to 21.
Yeah.
We work in the emergency room, so whatever comes in that day is what comes in that day. So I would say, yeah, it's really from the really itty bitty infants all the way to the adults that maybe have had like a condition that they see their doctors here still, because 18 is the cutoff, right?
Mhm.
You're no longer pediatric at that age, but once you're followed here, you're still able to come to the ED. So we see a lot of 20, 21-year-old sickle cell patients or 20, 21-year-old cystic fibrosis patients that come through the ED when they have fevers and pain crises and things like that.
And do each of you have a favorite like group? Do you prefer like the babies? Do you prefer teenagers? Like, is there a specific group that you like to work with better?
I would say, yeah, I love the preschool age.
Mhm.
Yeah, the preschool age would be my favorite.
I think I love school age. Love them all. Obviously, we're here for every age. But I think school age is my favorite, I have to say.
And then, another question from Isha. How do you ensure that your decisions are based on logic and professionalism rather than emotions when it comes to children?
Oh, that's a great
That is a
question.
good question.
So that's a difficult one.
I think that always going back to the developmental knowledge that we have, because it's very easy to say like, oh, I did this with this kiddo, so I'm just going to do the same thing with that one. But we know that not every kid has the same temperament, right? We know that not every kid has the same attachment style, so we have to factor in temperament, attachment style. They may be 6, but are they developmentally 6? Are they functioning as a 3-year-old? So I think those factors really help me stay professional and logical rather than just going in with my emotions and seeing, well, this is a cute 3-year-old. Let me run in and just go get them Bluey. But they might not be verbal at that time. So Bluey means nothing to them, but a sensory toy might mean much more to them.
I think we talked to you a lot in our coursework, and I don't know, Sarah, if you've had the same experience, but we talked a lot about boundaries in our courses because a lot of times we are working so closely and we're hearing things and we're present for things that are really vulnerable for patients and families. And so we talked a lot about, how to establish boundaries within ourselves to if you're feeling like you're getting teary-eyed in the room and you need a second, like here's quick things in your pocket, like be like, oh, let me just go run and grab you a water. I'll be right back. And then you can pull yourself out, take a second, like feel those emotions, because obviously you're going to feel them. We're all human too, but then you can come back and be more logical and more present and more responsive for the family, focusing more on them and less on yourself, is another sort of aspect too that I think we can kind of jump back to and rely on, which can sometimes be helpful.
Yeah, and since we are going a little short on time, we'll do one last question, but going on the same wavelength of talking about like emotions and having different types of patients, and like each patient you have to address it, and for that specific patient, it's not like a one size fits all. Have you ever had a patient that you felt like taught you something, like where you're like, oh, this is why I need to be patient. This is why I need to, I don't know, XYZ. It's like, because you obviously, I'm sure you learn a lot on the job, but is there ever a patient that like stuck with you?
I think there's a lot, but in a lot of different ways.
Yeah.
So like sometimes they'll stick with you because it's like, oh, I just said something and put my foot in my mouth, and like I didn't mean to say it that way. And their response is like shows you a lesson of like, oh, I should have worded that differently. One of my preceptors said along the way that's always stuck with me, which I know this maybe doesn't exactly answer your question, but it's coming to my mind right now, is that she was in a situation one time where a kid was navigating a really tough new diagnosis, and she said to them like, I know you're feeling upset right now. And they looked at her and they're like, you have no idea what I'm feeling. Like you don't have this diagnosis. I have this diagnosis. So you don't know that I'm feeling upset. And she kind of led a lesson with that for us one day. And I've never forgotten it, because it's one of those things that's like, I don't know how you're feeling, but it's something you're so quick to say, like, oh, I know this is probably so upsetting to see your kid cry right now. And so kind of like flipping the language and be like, oh, I can imagine that this is probably really
Right.
tough. Or I can imagine that some of these feelings might be coming up. Can you tell me more about what's bubbling up for you and what you're feeling? So that's one that I've always remembered, like outside of being here and starting this job. But then there's been multiple kids that even just like bring something up during a procedure that I'm like, oh, that's a great idea. Or like, oh, I could add that to the options that I give. Or like they tell us a trick or a tip that works for them, and we're like, oh, I'm going to add that to what I give as an option to all the other kids, since they're the ones going through it, they're the ones giving us the best piece of information to kind of then utilize for the next kid.
Yeah. Yeah.
All righty.
Oh,
Go ahead,
ahead.
please.
No, go ahead. Go ahead.
I was going to say we're out of time, unfortunately.
Sure.
Do you want to just make a couple of quick comments?
No, it is okay. It is all right.
All righty. Well, thank you all. Again, apologies for the little hiccups at the beginning, but we're glad our Nemours colleagues could join us. Excellent presentation as always. So Meredith and Sarah, thank you. And next week we're going to be doing laboratory with Christiana Care. Until then, take care, everybody. Bye-bye.
Thank you. Thanks, Tim. Thanks, Nicole.